so much for joining us today on Transforming Healthcare. I'm Wael Barsoum, and I have a real honor today to be joined by a very good friend of mine, Allen Passerallo. Allen and I have known each other, I think at least 20, 25 years now from our days together at Cleveland Clinic, and I'm very excited about what we're going to talk about. Allen has had an incredible career. After finishing up at Mercyhurst College, went on to Indiana Wesleyan, where he earned his master's degree, and then went on to Hammett, working as an athletic trainer, Mount Sinai in Cleveland, Cleveland Clinic, Johns Hopkins, and most recently, Vizient. So today we're going to talk all about all things really supply chain, performance improvement, incentivization, alignment, and ASCs. So I'm really excited to have you all with us, and very, very excited to talk with Allen today. Allen, thanks very much for joining us.
Well, thanks so much. Pleasure to be here.
Yeah, thank you. Thanks. So first and foremost, tell us about how you ended up where you are today. I mean, obviously an athletic guy, clearly, have always been in great shape, an athletic trainer, but now you're very much on the business side and working on a performance improvement and supply chain. How did that happen?
Yeah, it started off with just being on the athletic training side and having gravitating towards the business model, which enabled me to be a manager of 3 outpatient physical therapy facilities for Cleveland Clinic. It was a great experience, and not a lot of athletic trainers get an opportunity to do that, so I'm very privileged to have that. Knowing that I kind of enjoyed that part as much as I did about treating patients, I decided to go back to school a little bit later in life, got my MBA, and had an opportunity to slide over to supply chain. To be honest with you, I wasn't even sure quite what it was. All as I know is that my clinical background was supposed to help in the supply chain opportunities. So went over there and realized I'd be doing contracting and sourcing and partnering with physicians on unique models to help reduce our costs at Cleveland Clinic at the time. And that's how I tried to transition over there. So I was looking to advance my career. I kind of got outside of the scope of the traditional athletic trainer, which it's not really a high-paying job anyway. There's many of us out there who want to rehab and take care of athletes, but it was that business sense and operations mindset, I think, that kind of led me to that direction.
Yeah, that's incredible. One of the comments you just made, talking about kind of partnering with physicians at Cleveland Clinic, right? I mean, a lot of folks look at supply chain in the healthcare system world and see it through different lenses, right? In one way, they look at it from the perspective of, is this going to narrow what I can use? Is it going to malalign incentives between a provider and a healthcare system? But I think you were very unique in what you did at Cleveland Clinic. I remember you were partnered with Sean Lydon, who was the medical director of supply chain. And together you guys really came up with what I thought was a pretty novel way of engaging and aligning providers around the selection of physician preference items. Certainly in total hip and total knee replacement. I know you guys did it in the valve world and in the implant world. Touch a little bit about the philosophy behind that alignment and transparency and engagement.
Yeah, the organization, it was about the time when the Accountable Care Act was coming around. There was a great demand for cost savings as it relates to some of the Medicare reimbursement challenges that were out there. Executive leadership wanted us to save money, and we knew that if you try to go in with like a hammer versus a carrot, right, you probably weren't going to be successful. So the opportunity here was to engage with the physicians, make sure that we focused on clinical value first, or quality value first before cost. And I think that's what resonated with the surgeons. I think at first it was, you're going to tell me what to use, it's going to be at a lower cost, it's not going to be high quality, you don't care about patients. And in all honesty, we needed their help to tell us, what data do you need to help drive that decision? Do you need outcomes data? Do you need benchmarking from external sources? Do we need product attribution so we can say if we went from product A to product B or vendor A to vendor B, is it similar in structure and does it perform the same way? And some of those, you're making assumptions, but we in a supply chain are not there to tell a surgeon how to do a surgical procedure. We're here to breach the business and financial aspects with the clinical aspects, but do it in an objective manner so it wasn't just focused on the finance piece. So we definitely wanted to go in focusing on clinical. In fact, as we grew our team out, I would tell my team, I'm like, always put savings at the bottom of the slide and actually reduce the font, because we want to emphasize that we really want to partner and work on quality first and foremost. Yeah. So,
I mean, I remember when we looked at hip and knee replacement, the hip and knee replacement contracts. I think I was probably involved in maybe 3 different cycles of that. I was always impressed with the inclusivity of the process, right? Every doctor that performed surgeries in any of our sites, whether it was employed physicians, private practice physicians, everybody had an equal voice. Mm-hmm. And I also remember at the very end, it was a vote, essentially, mm-hmm. right? I mean, it wasn't supply chain telling us this is what you're going to use. It was supply chain asking us which of these implants or which of these manufacturers are acceptable to you, and we will now negotiate the very best contract that we can for that choice.
Correct. Yeah, and I think at the clinic we had a 60-40 split of employed to private practice physicians, and the feedback that we had heard from some of those surgeons, private practice surgeons' previous experiences were, if we're told what to do, they're just super resistant about it. So, in all honesty, they have great experience too, right? Some of them have done research, and we value those opinions. And even like contracts like trauma, really good impact or input from the private practice docs who say, Allen, we're at a level 2 trauma center. I don't do as many cases as like the level 1s. So therefore, I need a different level of service representation from the company. I need example trauma plates that have different flexibility in the whole structure where they place it for the fracture. And I'm like, I never thought about it that way. And so as we looked at those opportunities, we made that part of the process of evaluation before we decided whether we needed 1 supplier or 2 supplier. But I would say we never came in with saying we're going to go to 1 supplier every time. It was what do we need versus what do I want, right? And so therefore we engaged with the surgeons, got their feedback, put a matrix together from a product attribution standpoint, and then we assessed the opportunity. But we did show them at times, vendor A and vendor B are exactly alike. So do you need them both? And that's how we engage with them.
Yeah. So you've obviously worked at some incredible organizations, right? I mean, Hammett Medical Center, great system up in Erie, Pennsylvania, going from there to Mount Sinai in Cleveland, which was a real, top-notch academic medical center, for decades. And then, of course, Cleveland Clinic, Hopkins, and now Vizient. As you think through your career and lessons learned in some of those organizations, especially around managing cost, managing supply chain, working with clinicians, what are some of the lessons that really stand out to you from each of those sites?
Yeah, I think if I was looking at it overall, it was a great opportunity to learn that you cannot take a cookie cutter approach to cost savings from a general perspective. You have to look at the challenges that each of those organizations face. Like an example would be, you can drive cost savings, but you also run the risk of maybe a surgeon leaving because they're unhappy with the decision, and what is that revenue impact associated with that physician leaving? So I think as I went specifically from Cleveland Clinic in supply chain to Johns Hopkins, they function very differently. So we had to adjust, or I had to adjust with my team, the process of delivery engagement with those physicians versus the ones at Cleveland Clinic. And again, I think the administrative structure, executive structure, and the messaging around goals was extremely important. And I know in Cleveland, they had a really good process with their the CFO, which was they allowed the service line medical directors to have an ownership in the budget process. So it was not the administrator and supply chain driving savings to meet the budget gaps. It was surgeon, you actually own a part of this as well. So you need to partner with supply chain and figure out what's the best way to go about doing this. Knowing that the majority of costs come out of human capital and we don't ever want to touch labor, then clinical products, pharmacy and non-clinical products, that's the next opportunity for health systems. So how do you leverage your high expense items into a model in which you could maybe potentially standardize suppliers without negatively impacting care? And we know that market share drives lower costs. So,
yeah, I remember, over the years, certainly earlier in my career, there would be every year there'd be kind of a standard increase in the cost of a product, right? Whether it was 3% or tied to the consumer price index or whatever. It seems like those days are kind of over. And one of the things that I always really bought into was that you shouldn't pay more for a product just because it's new. There should be real clinical data. And by clinical data, I'm not talking about white papers. I'm talking about level 1 studies that show that product A is significantly better than product B. And only then should there be an increase. I feel like today we've even gotten to the point where we're starting to think more and more, that's probably not even enough. It has to be a transformational change, right? A robotic application, something completely different than what we were doing before. Is that how you're seeing things today and kind of in the real world?
Yeah, we take it from a value analysis approach where we look at the total cost of care related to that product or medical device, and we assess what the impact is. So to your point is, I know a lot of times we get surgeons who will bring a product forward and say, well, this is going to speed my time in the OR. Well, does it speed it up enough where you can get another case in? Are you driving efficiencies that way? Definitely you're going to look at quality to see, does it improve the quality of patient care, which is first and foremost. And oftentimes that's not always the case, right? So it's a Me Too product. It's just like the one that's on the shelf today. So I think a good value analysis process where you're looking the total impact to the cost of care is essential when determining whether or not to let new technology in.
Yeah. When you're looking at incentives, right, and obviously remaining compliant, making sure we're not getting in any trouble, but using incentive type programs where you can align a healthcare system, a payer, a provider to ensure that patients are getting the very highest quality care for the very lowest price. Wearing your Vizient hat today, what are some of the programs that you guys look to use to kind of increase that alignment and get folks comfortable with the fact that this is the right thing to do every time?
Yeah, it's an interesting question because GPOs have performed similarly for decades, right? Is you go out, you leverage your membership spend, you negotiate tiers, and if whatever tier you qualify for, you get the price point. What we're trying to do now is going into and speaking to suppliers. We're really big on bidirectional value. I'm personally not have a philosophy of let's beat down the supplier and get what we want. We're not going to get very far by doing that. Our goals don't align, but so how do we create a process that aligns provider to supplier and somehow they're both winning at the end of the day? So right now we're implementing more shared risk contract structures in which we have technology that measures compliance to agreements. Therefore, you don't achieve the maximum value like through a rebate unless you comply with the contract, and we have objectivity around measuring that. There's a lot of organizations out there who say, hey, we have committed spend and we'll make sure we buy for contracts. Well, some of those hospitals that are part of other GPOs come over to our GPOs, so we see the analytics and we know that they're not compliant with those contracts. So I think, again, we're trying to tell this supplier community, don't think about us like a typical GPO. We are really doing our best to hear what your challenges are, designing strategies that help both provider and supplier out.
Yeah, the whole idea around rebates, I'm not sure is really clear to people, kind of how that works, right? So maybe I'll explain my thoughts around it and how I think it works, and you tell me if I'm right or if I'm wrong. Sure. and correct me. So in essence, let's say you go into a system and they use 5 different manufacturers today, and each one has 20% of the market share in that system. The idea here would be to say, okay, we're going to go down to 2 manufacturers, maybe only 1 manufacturer, but we're going to guarantee you 80% of the volume. And if you get that 80% of the volume, you pay us back a portion of the overall spend. Is that about right?
Perfect, yeah. Great explanation. And again, oftentimes it's subjectively reported versus objectively, and I think that's where we have technology that enables us to measure that. So we have a brand new program right now where the provider and the supplier, they leverage that technology. They both see the same reporting time period within the tool, so they can both see if they're compliant or not. And the way we've structured the language is supplier gets to hold back a significant portion of the value if the member is not compliant with the contract.
Interesting. So it really is two-way risk in this.
Yeah,
in this
absolutely.
Yeah, that's great. So we were chatting earlier, and you were sharing with us kind of some of the work that you're doing in the ASC space, right? I mean, we're clearly 6,000 ASCs in the United States today, right? We're clearly seeing an increase in utilization, and we're seeing more expensive, more complex procedures that have higher supply costs associated with them shifting to the ASC. Total joint replacement's a great example, right? I mean, where today in an ASC setting, Medicare may reimburse $8,000 or $9,000 for a primary total joint replacement in an ASC setting. Obviously, the cost of those implants becomes important. How do you guys think about this shift from the acute to the, I don't want to call it non-acute, but less acute environment, right? Doing the right procedure for the right patient in the right environment. How do we make that more manageable? How does it make a difference for patients? How does it make a difference for providers? And how can you guys help to enable that transition?
Yeah, it's interesting. Some of the payer contracts are actually, even with hospital contracts that are performing the surgeon HOPD, they're requiring them to do a certain percentage in the ASC market. Co-pays are lower, cost of care is lower, so out-of-pocket expenses are lower. We know that the ASCs were originally designed, most of the original ones were designed for general surgery procedures, so not trays of implants like occurs in hip and knee. Additionally, besides a lack of space, is the ability to do sterilization. So that sterilization is an add-on cost. So whether you have to build out your ASC or you outsource it to a third party, that's increasing your overhead and your margins start to shrink, along with every other factor in healthcare right now, whether it's tariff or inflation. So our philosophy was we have a company called SG2 that does forecasting analytics in healthcare. And we polled several freestanding ASC physicians who commented that 70% are the primary decision makers when it comes to selection of product. Of the over 200 that we polled, 60% said, if I could save 15% or more on my implant, I would change suppliers. So we know that the financial piece or the concerns are there, and they're looking for opportunities to improve their margins. So how do they go about doing that? So our program is designed specifically for orthopedics, where we have 10 contract categories. A member who joins has to access 70% of those contracts, and 65% of their spend has to go through those contracts. And for that, we utilize physician input, we utilize relevant clinical research, and then product attribution to ensure that we have all the technology that a surgeon would need to provide high quality care. We know that, for an example, our first 2 contracts are hip and knee and bone cement, and we've been able to standardize to a single price point with that contract, which is offering significant savings to ASCs. As an example is our first member, which is Atlas Management Company. We're saving them anywhere in their model somewhere between 28 and 65% on a total joint implant. Wow. And oftentimes that's a concern: are my physicians going to change? But if you think about their incentives for improving margin, if you save them $1,000, which is really realistic in our strategy, is they do 100 cases a year, another realistic opportunity or quantity. They're saving they're making $100,000 extra. Now, money isn't everything, but depending on how they structure their ambulatory surgery centers and where that money flows from, either reinvestment or from a compensation model, pretty significant is the opportunity. So we're building this out right now. We're soft selling. We have 4 more management groups that are in alignment. We think it's an attractive model for private equity as well. They like to invest, get in and get out. They want to see improvement on their investment. So we're excited about it. We are transitioning from orthopedics. Our next group is general surgery, and then it'll go to cardiovascular. And the reason why we delayed cardiovascular surgery so long was because the demand for capital equipment is high, so definitely higher levels of CT scans and what have you. And the cash flow is a challenge for them, so we are working towards that as more codes get approved for the ASC space.
The outpatient space, yeah, that's terrific. You touched on SPD, right? Surgical processing, inventory management, and you're absolutely right. Older sites that weren't built to sterilize the number of trays that we use today in an ASC setting, or even storage facilities to store all the implant boxes and whatnot. Where are you guys thinking about just-in-time inventory management, off-site surgical processing? Are these things that are front of mind for Vizient today?
It is not quite there in the contract agreement, but knowing that ASC struggle for space, right? As we talked about earlier, is whether they want to expand their OR operations or they just want to expand their SPD operations. We're coming close to advancing on a contract with regards to modular units that you can actually plug onto a side of a building, or it can be freestanding off-site. And the advantage of that is, one, it's because it's modular, it's, while you're prepping the land, you're building the facility inside of a warehouse, and then it's Legos, you're plugging it together. Hurricane proof, tornado proof. But the big advantage is from a cash flow perspective. You build a building, it takes you 18 to 24 months, and you have to depreciate over 29 years. On this structure, you're building it while you're prepping the land, so it's 9 to 12 months to launch, and it's an asset, and the asset is depreciated in 7 years with 45% year one. So it's an advantage from a cash flow perspective. So again, private equity who are partnering with ASCs and saying they want to grow their footprint, this is a great opportunity for them. And we don't know of anybody who else out there who's doing that, so we're excited about getting this in front of the ASC community.
That's great. So you started off as an athletic trainer, and brought some of those skills to the work you're doing today. Just touch for a minute on at least what you feel are some of the benefits of having a clinical background that you can now kind of draw on as you're working with orthopedic surgeons, as you're working with general surgeons, other clinicians. Is that beneficial, do you think?
Definitely. I mean, I think treating patients, we interacted with surgeons like yourself about progress of your patients and then whether there was challenges or not. I think from my backgrounds, I have enough clinical knowledge maybe to be dangerous, right? So if I'm talking with a surgeon, they're bringing forward a discussion that is about anatomy or physiology, I can relate to it, I can answer the question to it, and I can apply logic that says, here's what's coming from the implant side of what's impacting the surgical case. That is somewhat of a unique skill set as opposed to a supply chain or business person who can't connect the dots on that with a surgeon. And I think you build credibility with the surgeon community by doing that. So I think I would have never thought, when I switched from to supply chain from athletic training, I was almost like, I can't believe I went to school for that and I'm not going to use it anymore. It's an incredible advantage in speaking with surgeons.
That's great, that's great. So last question for you. Where do you see this industry moving in the next 5, 10, 15 years? Data, digitalization, just in time. I mean, where are the opportunities?
Yeah, I think that, there's going to be that continued push to the outpatient setting. What's interesting about that ASC space is data availability is not as strong as it is in the acute care setting. We're positioned pretty well. We have a clinical database that over 97% of academic medical centers access for reporting to CMS. And in addition, we're capturing non-acute data in that system as well. We're able to benchmark clinical outcomes along with cost data because we have another system that both ASCs and acute care hospitals are pushing their spend data through. So we can actually marry up cost and quality data, which I think is advantageous for benchmarking against your peers as well as helping negotiate payer contracts. I think that's going to continue to take a strong position in healthcare. I think AI is going to enable us to analyze data quicker than we are right now. It's very manual at times. We're leveraging AI significantly right now in our organization, and our teams are getting educated further and further, like how do I combine reports out of multiple systems and then basically punching in and say, analyze this data from a cost quality standpoint and then spitting it out. So our ability to provide services to both acute and non-acute care facilities, advise them where there's opportunity from both quality and cost is present. I know Hopkins leading the way from a quality cost perspective, and we focus a lot on cost, but I think having some of the data that we have through our tools is going to be able to support all initiatives when it comes to value-based care.
That's awesome. Allen, I can't thank you enough for your time today. I mean, it's you've always clearly been an expert in this area, and for many people it's opaque, right? So hearing from somebody like you about where the industry's going, where the opportunities are, how to better partner, the importance of transparency, I think is absolutely wonderful. So thank you so much for taking the time.
Thank you. I appreciate being here. Thanks so much.
Yeah, of course.